the affiliation into the chat box. This is for grant purposes. We are grant funded to continue these webinars. So we do need that information so we can show CDC that we are making progress. If you're not from Montana, we just ask that you please include the state that you are from. And if you have multiple people joining, please do include everyone that's on the call with you. And then if you want, you can turn your webcam on. We'd love to see your smiling faces. All right, Vince, I think we can get started. Looks like people are starting to put stuff into chat.
Okay. Well, welcome again to another installment of our stewardship seminars. And we'll talk about this a little bit down the road here, but we continue to seek feedback and responses, reflections, and so on and so forth from all you practitioners out there on anything and everything. Are these, and I think Erica's, she'll maybe mention this, but we're going to do a kind of a Qualtrics poll and get some more data from you, some more information from you in terms of like, is it helpful? What's not helpful? We know there's a diversity of folks out there, and some of it is over your head. Some of it's probably under your belts, and some of it's like right down the middle of the pike. And so, but we want to know that, and we want to know what else we can do, and more importantly, how we'd like to be able to engage you all and get some more participation, because what you're seeing out there, it's not unique, and I think we're all exposed to it, and we all have questions. We probably all have the same questions that you have out there. So we want to know about that. And so, that old adage of no, the only question that's stupid is not the one that's not asked. And so we want all that stuff and different topics and engagement and participation. So I'll jump off my soapbox there. Today is my pleasure to introduce Amy Ross. Amy is the Director of Pharmacy at the LTAC in Billings, the long-term acute care facility. So she's going to educate us on what that is and the principles out there, their modus operandi, and how they vet people coming in and the patients that they see, the criteria that they use to select, manage, and so on and so forth, and how they're applying those stewardship principles to their ID folks out there. Okay, so with that, Amy's graciously agreed to educate us all. So Mrs. Ross, I'm going to let you have the floor.
Thanks, Vince. Thanks for the invitation to talk about our level of care. I'm going to try to share my screen here. Let's see if it works. You can see my slides. How's that look?
Perfect.
Does it look okay? All right. I don't know how much education I can do, but maybe you'll pick up one or two things that you didn't know already about this. Different level of care, long-term acute care hospital. We're the only one in Montana. So we'll go over what is an LTAC. We'll review the NALS criteria, also CMS admission criteria. NALS stands for National Association of Long-Term Hospitals. We actually don't have a subscription to NALS right now, but we used it when we opened, and it's a gold standard. It's pretty basic, so I think it's still useful, and certainly our liaisons use it when they're evaluating patients. We'll discuss our scope of service, because there are some things that we don't do, not able to do, and then that all leads us into antimicrobial stewardship challenges that we've got at this level of care. And I've got a brief case study that we can review also. So a little history. What is a long-term acute care hospital? Developed in the early 1980s to offload short-term acute care hospitals. So in Billings, that would be St. Vincent's or Billings Clinic, a short-term. acute care hospital stack has a length of stay of 24 hours, 3 days. Really, they try to keep it down as much as they can. And also to decrease Medicare fees. Patients that, because of their high medical needs, because of their complexity, because of the nature of what brought them in for their acute hospitalization, they weren't able to return home or to a lower level of care, to a nursing home, a SNF, or whatever. So they stayed in the short-term acute, and they occupied a bed, and they increased costs. And the people at CMS and others decided we need a different intermediate level of care for these particular patients. The first one was in the East Coast. It kind of went all the way down the East Coast and then moved west, but then it kind of stopped. And there was a moratorium in like 2002 because they were popping up everywhere and it was a little bit out of control. There's a couple different kinds of LTACs. You can be a standalone. We're a standalone here in Billings, which means we are a building by ourselves. There can be long-term acute care hospitals. There's like a floor in a short-term acute. We're the only one. We're like 20 minutes outside the medical corridor, and that has its own challenges as well, and we'll talk about that as well. Post Falls, Idaho has got an LTAC. Minot, North Dakota has got an LTAC. Rapid City, South Dakota has an LTAC. Johnstown, Colorado has an LTAC about an hour north of Denver. Those are the closest LTACs. So it's pretty rare still in the Northwest. A good definition for an LTAC, an acute care hospital that specializes in the treatment of serious medical conditions that require ongoing care, but no longer require extensive diagnostic procedures. And that's important because in our little 40-bed hospital, we don't have an MRI scan. We don't have a CT scanner. We don't have an operating suite. We don't have, since we're a standalone, we don't have consultants right next door. We are outside of the medical corridor, so it's complicated. Patients should be coming to us with a diagnosis, or at least have the primary issue worked up. That doesn't mean to say something minor doesn't, become major during their stay, but generally speaking, they come to us with a working diagnosis and a plan of care, and that's what we base our admission on. We have liaisons in the community that provide a reference. They take the referral from the short-term acute care hospital physician. They evaluate the patient based on their needs and NOLS criteria and what we have available in-house. And if they feel like the patient is appropriate for our level of care, they present them to a daily operations team. And it's a diverse team. There's the clinical people there, the physicians, pharmacy, nursing, also a business meeting. The CEO is there, the business office is there, marketing is there. And it really is a group discussion on when we can take this patient, when would be a good time. And it's really frustrating to some of our referral sources because we might take a patient on Monday and a very similar patient on Wednesday we won't accept. We'll pick them up next week when we have a bed open. There's a lot of things that go into the decision: discharge plan, staffing, supplies. Sometimes there's a question, they need to get a CT. Would you consider this before the patient comes? Sometimes our providers have questions, and they have requests and want to talk to a physician before the patient comes. So not black and white admission criteria. There's a lot of gray. Scope of services are geared toward patients who have had a recent ICU stay. So we take a lot of our patients when they're ready to transfer out of the ICU at the short-term acute. Prolonged stays, we've got a patient in-house right now that has been in the short-term acute since January. Finally plateaued, not improving, stable enough to come to the long-term acute care hospital. and came to us, and we're trying to wean oxygen and get them stronger to get them to the next level of care. And then also repeated hospital stays. We hear this all the time, where a patient will admit, they'll have antibiotics, a procedure, a debridement, and then they'll discharge. And then a month later, they're back. They admit with the same issue, they get tuned up, they discharge, a month later, they admit again. We try to break that cycle. That's a lot of times when we get our referrals is from that kind of patient that are in and out of the hospital and exposed to antibiotics every time, you just know it. Try to break that cycle. So that's part of our antimicrobial stewardship challenges as well. We're licensed by the state as an acute care hospital. We are CMS certified as an LTAC. We have accreditation to Joint Commission. We have an additional disease-specific certification, respiratory failure. We do a good job weaning people off the ventilator, decreasing their oxygen, decannulating. Our VAP is 0 basically for reporting. So we do a pretty good job. So let's go over some admission criteria. We like 90% of our patients are CCI, chronically critically ill. They are dependent on intensive care. They experience a high symptom burden. They have repeated episodes of illness exacerbations. They have communication barriers, and generally speaking, they have poor health outcomes. So they need specialized and complex care, and needs can't be met at a lower level of care. So that would be a nursing home or an inpatient rehab or home with services. Sometimes if the admission criteria is a little fuzzy, maybe we think they're a little borderline for our level of care, we'll ask, can you please refer this patient to ROM, the Rehab Hospital of Montana, which is just a neighbor of ours, which is an IRF. If they deny, then that would be admission criteria for the LTAC. A lower level of care cannot take care of this patient. So sometimes we do that. They are stable for transfer and no longer appropriate for care in the current setting. Talked about respiratory failure. They need vent weaning. They need intensive respiratory care. We've got a tremendous team. Multiple IV medications or infusions. Complex wound care. We have some pretty impressive wounds out here. Under CMS, expected length of stay is greater than 25 days. So that's different than the short-term acute, which is 3 days or less. We'll sometimes go 5. They try to keep it as low as possible. We have to be at least 25 days. They have to be in the vent, on a ventilator, in the ICU, or on telemetry for greater than 96 hours, is what CMS asks of us. So a typical patient population, we talked about most of these, so that just a couple more to pull out. Extended courses of antimicrobials. So these are patients that can't have unsupervised, unmonitored IV access. They would not be compliant with their outpatient antibiotic plan. And they would use their IV for other things, so they need to come to us. They need to be seen by a provider every day, and we talked a little bit about complex wound care. We've got a very strong plastics group here in Billings. Dr. Musket, Dr. Grosso, and Dr. Gallagher is new. They're out here 2 or 3 times a week assisting with our wound care. They also participate in the administration of our facility. Dr. Musket sits on our medical executive committee. We really appreciate their help. And then our patients are heavy with indwelling devices, drains, chest tubes, IV access. Some of them have ET tubes. Some of them have trachs. Some have pegs. All the things, right? There are some services that we can't provide. We can't provide patients who require dialysis. When I started out here, we did have a contract with DCI, St. Fee's Nephrology Group. That group dissolved and went through some changes, and our contract kind of dissolved with it, and we just never have picked it back up again. Patients who have made comfort or withdrawal of care decisions, We certainly transition patients to that service, but that's not an admission criteria. It's not something that we specialize in. Patients needing immediate surgical intervention, obviously limited in our ability to perform anything like that. We do some bedside procedures. We do a lot of wound debridements, especially with our plastics people, but our hospitalists also have that in their credentialing. We do bedside trachs, we do bedside pegs, and then chest tubes, central lines, all the things. We do some of that too. Just quickly, a little bit about us. We opened in February 2008. We're 40 beds. We've got 8 ICU beds. We've got critical care, intensivist doctors rounding on those patients. Our medical director is a pulmonologist. We've got 32 med-surg beds, and we have hospitalists. We can do some basic radiology. We can do some flat plates. We have a lab partner with the Billings Clinic. Our nurses provide phlebotomy. And then we have a courier system that takes those samples downtown to the Billings Clinic. We have an infectious disease partner with the Billings Clinic with contracts. They help me with the antimicrobial formulary out here, and they support our restrictions. We have restricted antimicrobials that require an infectious disease physician prior to dispensing. We have an antibiogram specific for our hospital that Billings Clinic lab microbiology work on every year, and Dr. Prager has reviewed it for the last 4 or 5 years and given education in an in-service and talked to our providers, which is tremendous. Before that, it was Dr. Reese. And then, of course, one of my favorite local expert resources, Dr. Ott, Dr. J.C. Ott. I am very grateful to her for counsel. I think it was interesting for May just to see admitted 42 patients, discharged 44, so you kind of get the flow. We move patients through our facility pretty fast. We've got 40 beds. That goes to Antimicrobial Stewardship also, as well as this slide. This is the list of all the patients that we have admitted year to date. And you can see just by looking at the list, they are from different cities. They are from different counties. They are from different states. They are from different regions. We're bringing all of those patients to this hospital in Billings, Montana, which leads us to challenges. We concentrate patients with medically complex situations, multiple comorbidities, and they're here for our length of stay, 25 days at least. We do not have all services required in-house that may be required. We would need to use our community resources, which would be the short-term acute. We don't have a CT scan. We don't have an MRI. What if the patient is doing poorly and needs to transfer back to a higher level of care? That means a trip to the emergency room at the Billings Clinic or St. V's. So it really is a partnership in our community. Our patients usually have a history of extensive antibiotic use. They are most likely, I suspect, colonized with MDROs. We have not done a point prevalence survey, so we don't know. And we'll talk about that in a minute too. Our patients usually have an extensive device use history as well. Does anyone have any questions about kind of the LTAC and where we fit in before we go into the case presentation? Okay. So we had a patient referred to us last month with acute and chronic osteomyelitis of a right ischium, had been debrided, coming here for post-op wound care, long-term antibiotics, and monitoring. The patient was presented to the operations team. Great LTAC patient, definitely met criteria. They placed the patient on their ACHM patient list in their electronic medical record, and those of us that have access, I've got access to as many places as they will give me, Billings Clinic, St. V's, Great Fall, all of them. We were able to sign into their EMR and take a look around, and in an ID progress note under the assessment number 5, it said this patient had KPC, this is verbatim out of the note, club pneumo, carbapenemase resistant, and VRE colonization. Interesting, kind of got my antenna up. I didn't hear that in report. Found micro, a variety of tissue was polymicrobial, and then at the bottom there was this sentence, Klebsiella pneumoniae organism is a carbapenemase producer, which that's different than just a carbapenemase resistant organism. And at that point, you could knock me over with a feather. I didn't think we had one in Montana, but I'm kind of out of the loop out here on the West End. So I started calling my resources. And I got a group of people in the building together, myself, the director of nursing, director of compliance, marketing and business development director. She's actually an ICU nurse and is a tremendous clinician. I think I called JC first, Dr. Ott. She's probably regretting she ever gave me her contact number. And then I talked to Dr. Prager, who's an infectious disease physician here in Billings, 2 or 3 times. Reached out to Erica, also probably regrets giving me her contact information. And then I called Riverstone Communicable Disease Department, talked to them. I didn't know about transferring this patient across county lines, if there was anything that I needed to do. Come to find out, in this particular case, there wasn't, but they appreciated the information. We reviewed our contact precautions, good news. All of our rooms are single rooms, and they all have a private bath. Reviewed the rest of that. We checked our cleaners. We talked about contact time, donning and doffing. We looked at our hand hygiene and PPE audits. And then we had some concerns that we just couldn't reconcile, and they kept coming up in the conversation. We knew from the progress notes that the KPC was a colonizer, but with colonization, isn't it just a matter of time before it becomes clinically significant? Certainly if a patient's with us for a month or more, it's concerning. Moving this organism to a different community and potentially sharing it with the short-term acutes, ambulance service, over to St. V's for a CT or an MRI, going to a procedure, maybe in the OR, waiting room, recovery, back to the emergency room, ambulance service, back to us. That's a lot of contact, and we were concerned about moving that organism to this community. One thing that JC said at one point is, just let me know, and if I need to get some meropenem vapor-bactam in, I will. So we were going to essentially change the antimicrobial inventory at one of our partners. Have a problem with that. Might have to. If the patient was doing poorly and needed to transfer to a higher level of care, we would send them to the Billings Clinic. So it was a concern. And then, of course, we had 35 patients in-house at the time with different levels of immune deficiency, and really they are our number one concern. So we were unable to reconcile, and ultimately we decided we weren't ready to contain this organism. We weren't ready to treat it. Certainly that specialty antimicrobial is not on our formulary, and I don't have it available if the patient were to become ill. we decided to take it as a wake-up call. This is our patient. Absolutely met criteria to come here, and we needed to redouble our infection control efforts. And that's kind of a list of the things that we did. Beefed up our audits. We started posting staff outside of contact precaution rooms for in-time intervention and education. Made sure our bundled care sets were being used and available. We hit the morning staff huddles hard. For probably 2 weeks, we hit the morning staff huddles, and then the timing of this was right before a quarterly all-staff meeting or a town hall meeting. And so we threw a bunch of slides in that and talked a lot at the quarterly staff meetings about infection prevention and control and hand hygiene and all of the things. Housekeeping and nurses received some additional targeted education and demonstration. And then Erica was actually coming to town for something else, and was very grateful for her time she was able to give us in-service. We had 4 admits that day, so it was very busy on the floor. So we didn't have a full room, but we had her on a conference line, and we recorded it, and I've had a lot of good feedback ever since then. And then we talked about doing a proactive point prevalence survey, again, at senior leadership this week, talking about colonization and the MDROs that we suspect that our patients have, but we don't know. We don't know what they have. And would it be nice to know in advance for prevention and for communication, especially if we're sharing with our community members, our partners. We talked about it again, and we'll continue to talk about it. There is a concern about the stigma associated with MDROs and being identified in your facility. And somehow we have to, I'm open for suggestions. I would love to hear what other people say about how you overcome that stigma and actually can identify the patient and move forward with that. So that is actually my LTAC spiel and a quick case study, and I would take any questions, comments, or suggestions.
Well, Amy, that was excellent. So yes, absolutely. Questions, comments, suggestions, anything out there, I think. Erica, I had a, when Amy contacted you on that, how did you approach that from a stewardship standpoint?
Yeah, so I think one thing that this whole thing made us recognize, and we've been starting to hear when we go out and do our infection control assessments on site, is that it just doesn't seem that a lot of facilities or individuals are aware of these different types of multi-drug resistant organisms and really the implications that come with them when we do have a patient that's positive for one of these, and how to care for them and that kind of thing. And so I know that internally we had to kind of do a look at ourselves, at our section, and say, I think we really need to do some training on this. This is the first, we believe, kind of Montana acquired carbapenemase producing organism in Montana. So we have had a handful since 2019. On average, I get about 1 to 2 cases of a carbapenemase producer reported. Most often they are the NDM positive, which usually is related to healthcare outside of Montana, and we've been able to link it. This KPC positive KPC is the most common carbapenemase producing gene in the US right now. The others are becoming more and more common, but so this one, it was kind of a wake-up call of I think we do have these in Montana now, and that we need to be really vigilant about identifying. My role in the investigation was to give Amy infection control guidance on the containment of this if they did accept this patient. As Amy alluded to in her presentation, there's a lot of prep work that has to go into this. that I think a lot of times, we didn't really even think about, other than, hey, you've got this patient, now what? And so there's the prep work of getting staff ready to handle an individual who's going to be on contact precautions. So within the acute care setting or the LTAC setting, it is still recommended that individuals be placed on contact precautions for the duration of their stay, and that we look at environmental cleaning and PPE usage. So it's a lot of prep work for staff of, do we know how to don and doff PPE correctly? Do we know what contact time is? Do we have a cleaning product that's approved for this type of organism? Do we know what wet time of that product is? Do we have a plan if this patient needs PT or OT, right? If this patient needs to go somewhere else and get other services, how are we going to get that patient from location A, which is their room, to location B, which would be, maybe the physical therapy department or something like that? When do we schedule this patient to have their therapies done? We recommended to Amy that if this individual needed physical therapy or OT outside of their room, that we would want to do it at the end of the day so we could do a terminal clean afterwards, right? Which then means you need to get your OT and PT staff aware of what a carbapenemase producing organism is and what the correct precautions are, because staff still need to be in PPE when caring for this patient at any time. So it was a lot of kind of Amy and I trying to come up with a game plan of every scenario that could happen. And of course, we're never going to be able to identify every scenario that's going to happen. But I think the biggest thing, and I give mad kudos to Amy, she has kept me in the loop every time they've had even a carbapenem resistant organism, right? Not even a carbapenemase producer, but she'll let me know and say, hey, we've got a CRE coming in. Or, when this CPCRE was coming, or KPC positive CPCRE was headed her way, the other facility didn't tell me. They had not let me know that this patient was being transferred. And so I was really happy Amy let me know, because as she said, it wasn't really super clear that this patient was a KPC positive. And this is, the biggest concern with these organisms is if communication is not relayed from the transferring facility to the accepting facility. If that patient is not on contact precautions from the minute they are admitted, we would have to do a point prevalence survey and identify close contacts and identify individuals that may need to be screened for colonization or for infection, right? So these investigations are pretty big. They take up a lot of our time, but I just so appreciate Amy keeping me in the loop on all of this, because it does take, I think, everybody's involvement when we do have one of these cases to really help prevent transmission or a breakdown in infection control at either the accepting or receiving facility.
Well, thank you, Erica. I really appreciate your support and you saying that, because I keep thinking you're going to change your phone number.
Nope. I think I'm stuck with this cell phone number as long as I'm in public health. Too many people have it.
Wow, that's a lot. That's extensive. That's great work, you guys. So, Amy, I have a question for you. Do you at your LTAC there, do you guys have an antibiogram, and what organisms are you seeing there that pop up in terms of troublemakers?
So we do have, ever since I started out here, we started developing our own antibiogram specific for our facility,
right,
because our facility is different
right,
than St. Bees and Billings Clinic. And when we came into the community, actually about 2 years later, I was talking to Nancy Iverson, and they noticed a difference in the Billings Clinic antibiogram because of the sharing of patients and procedures and overlap. Absolutely, they noticed a change. We have problems with gram-negative, I think, as most people do. Our MRSA, our Staph aureus, is about 50% of our cultures, still susceptible to vancomycin, MIC of 1 or less, but really it's the gram-negatives, the Enterobacters, E. coli, Klebsiella.
Okay. Yeah, I just wanted to kind of get your take on that. Jeff Jansen at St. V's, we were talking a couple of years ago, and his argument, and it's a valid argument, but he wanted to construct an antibiogram for the state of Montana, and I think it would encompass a lot of the same tough bugs that everybody encounters and needs to treat and so on and so forth. However, to underscore your point, you're a different bird out there. And so different places will have different organisms that pop up. And so we encourage everyone to kind of, look at their own antibiograms and organisms. And if there's something different that pops up, we need to kind of pay attention to that. So I think there's some overlap, but there's also some individual perspective that needs to occur in each side. What do you think on that, Neil?
I agree. And I think, this discussion about a statewide antibiogram is helpful from an epidemiologic standpoint, but for the individual critical access hospital may not be as applicable because you're not getting referrals. Most critical access hospitals send out their patients, not receive them. And so, and comparing Billings Clinic to advanced care, your advanced care's catchment area is much larger than ours. You're accepting patients from other regions that we don't normally get referrals. So and that makes it a little bit more challenging because you now have to consider other states, right? You're getting Western Dakotas and maybe potentially Idaho and Wyoming. We may get Wyoming, but we definitely don't get Idaho. Rarely will get South Dakota. So it is kind of tricky with that. Now, for those, and I'm going to kind of step back a little bit because we're talking about antibiograms and how to apply that to antibiotic stewardship. I mean, it's, I don't know, you recall one of the, what I presented last time was using the antibiogram to look at how effective your antibiotic stewardship interventions are. And so this is one of those cases that it's going to be a little different because Amy won't be able to use that because her antibiogram is going to be so much different and is not going to be a response to intervention. It's really more of a reflection of what patients they get to advanced care versus other facility where more regional, more local patients are more locally, like a critical access hospital. That's a little bit more useful in that sense because, because most of the residents in that area will just go to that one site. So these are actually different applications of looking at antibiograms, and we could certainly devote a whole lecture on it. But just kind of want to bring this up, but as that this is something you can't that can be used, and that's as an indicator. It's just you have to kind of look at it from a very different perspective.
Sure. Great point. What other questions you guys have out there?
I think Billings is a very interesting kind of healthcare setting because we have so many different facility types, and we see a lot of interfacility transfers between, both acute care hospitals, between the LTAC, now the rehab hospital. It has one of the highest number of long-term care facilities and assisted living facilities in the state. That when we do have an event like a carbapenemase producer, I'm often having to call, 3 or 4 facilities and say, hey, we had exposure here, 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 and here. And I think that's an interesting challenge of Billings, especially, is how many different facility types you have. And then, like Dr. Q said, the referral network that you see, you're not just getting Montana patients, you're getting patients from other states as well. And so we kind of have to be aware of what their epi looks like, right? What carbapenemase producing organisms are they seeing? North Dakota and Wyoming are similar to us. I talk to the South Dakota epi all the time though, and they have more carbapenemase producing organisms than we're seeing. Idaho's pretty similar. I think they're trying to kind of work on their surveillance a little bit. So it'll be interesting to see, I think, what unfolds within the upcoming years from Idaho. But, Utah definitely sees these types of organisms. So I think just keeping that in mind. The other thing is, you may have a lot of individuals that end up coming back to your facility after they've been at an academic center or a larger hospital out of state in Utah or something like that, right? And so those are things to be aware of as well, because they've had outbreaks of carbapenemase producing organisms within certain healthcare settings and in different states. And so a lot of times, that's why I got into epi and why I love the job that I do, but it's it's a lot of having to kind of connect all the dots. And I think, billings is definitely one of those areas that I keep an eye out on. But I think that also, goes to say that I don't think our critical access hospitals are immune to this. I think that this could show up at any of our healthcare facilities, especially with us identifying one that we do believe was acquired here in Montana, that we all need to kind of be aware of what do we do, what type of testing, and what red flags do we look for, right, Amy? When you said you were looking at the lab report or the report from the facility, there were some things that you said, hey, you know what, I need to stop and look at this further because that's a red flag to me. And I think being able to identify those red flags and having somebody that can do that is really important within your healthcare setting.
I love having access to other people's electronic medical record on the patients that we refer, because if I have a question, I can dig in and look for myself. And honestly, it frees up the liaison to do what they need to do, which is screen prospective patients and work on referrals and insurance and all the things that I don't have anything to do with, but they do.
So Amy, kind of in that regard there, and based on what Erica's response was in terms of how you guys handle this and everything that became unveiled during that process, how did you change, or did you change any of your stewardship principles initially, in terms of say, like, when you get a new patient, do you look at everything the same, or do you have more of those red flags that, say, Erica was talking about, that now go searching for in everybody just as a check off, or to rule in, rule out, or is there another stewardship principle that you put up front that you reprioritize, that you want to look at first or go after first before anything else? Did this change your paradigm at all?
Not really. We have always tried to communicate and review, tried to use good PPE, hand hygiene, appropriate use of antibiotics. That's why I almost always start reviewing a patient with the ID notes, because I think infectious disease physicians have got a real interesting way of assessing a patient. It's very big and varied, and they look at the entire patient, not just an infectious disease. I guess one thing did change, though, with our education. We pulled the liaisons together and said, we need you to be looking for this specifically and communicating. And that's something that Erica had mentioned, maybe we could have improved upon with this particular case. We need to be talking about it, and we need to be assessing risk. But as far as antimicrobial stewardship, I don't think it changed much. If you could give me some ideas, I would love it. We're kind of by ourselves out here.
Yeah.
Part of Ernest Health and Vibra. Vibra's in Pennsylvania. Ernest Health is in Albuquerque. We're the only one in Montana, and we are pretty advanced in a lot of things. We kind of do our own thing out here. We don't have a lot of support from our home office. So I would be interested if you have any suggestions.
Okay. Well, Erica, you made a nice point in terms of, like, I don't think anyone's immune from stuff like this. So I think our vigilance and antennae have to be up across the state in all of the critical access facilities for some of the, and that's kind of what stewardship, one of the components of stewardship is being aware of all this stuff. So what else out there, you guys? Anything? Questions, comments, reflections?
Vince, may I just kind of add a more
Sure.
of a take-home point for this?
Absolutely.
And just to kind of, because almost all of what Amy's talking about is more than likely not going to be applicable to you. And again, because as just for the reasons I pointed out, but why it's stewardship, and there's really two stewardship issues that we're really kind of addressing, and we're kind of mixing them together. There is what most critical access hospitals should be doing is to prevent the development of these organisms. That's really why, and that's why the judicious use of antibiotic therapy and things like that. So, because I mean, and it's easy for your clinicians to put someone on carbapenems because, you know, most clinicians believe that that's the broad spectrum go-to antibiotics. And obviously, the more exposure that patients get to with that carbapenemases, the more likely that you will end up isolating, creating isolates that will be develop resistant to that. And that's kind of how it evolves. On Amy's end is that she's more receiving patients with that already built-in risk. So their antibiotic stewardship intervention is going to be more focusing on, okay, I got these patients with these MDROs, what do I do when they get sick? And so that's really kind of, and that's a little bit on the different side because it's, you know, the options, treatment options are much limited on her realm. And what her goal is not just to make sure that patients are treated appropriately, but to preserve whatever remaining options she has available. So there's really kind of two very different spectrum in this. So the critical access hospital aim to prevent development of these resistant organisms, treating using antibiotics when it's appropriate, like when there is an infection, and that avoid and try to use directed therapy so that, you know, you don't need Zosyn to treat a cellulitis. Whereas she is going to try to figure out, okay, got a guy who has a KPC, okay, how do I going to treat this patient appropriately when they get sick with that bug? And how do I prevent it from that bug getting smarter and become resistant to all the other antibiotics? So there are really two different goals in this, but they're kind of the same principles. We're trying to preserve, you know, again, prevent further evolution of more resistant bugs and preserve whatever what treatment options we have readily available.
Excellent point there, Dr. Koo. And I think your last statement there in terms of like that overall prevention and looking at the judicious use and minimizing that risk of, you know, growing some Godzilla in your or gorilla bacteria in your environment, whether it's something that you haven't seen or something a different population like Amy sees on a regular basis. I think that principle is the same, different populations, but we're certainly trying to prevent that spread of resistance for sure. Great point. Absolutely. Anybody else? Well, Amy, that was very good. Thank you for presenting to us and educating us. I certainly got educated. I don't know that I could pass your post presentation exam, but I got educated.
I know you could. Thanks for the patience.
Yeah. Anybody else? Erica, anything else that you want to add there, Jenner?
I think this just goes to show why the services Jenner provides and the students that Jenner's getting to provide to our critical access hospitals on that days of therapy review and looking at prescribing practices. And Jenner, I'll let you talk more of what you're doing, but I think that's why it's so important that we're doing what we're doing and working so closely with these critical access hospitals, because it is important that we're good stewards. Because, you know, just like Dr. Q said, you know, by the time they get to Amy, sometimes we're kind of, you know, already down that path and we might already be dealing with someone that has a carbapenemase producer, but working at, you know, the critical access hospital level to really help kind of keep things in, you know, how they should be and being good stewards. So Jenner, I don't know if you want to kind of add on to that, because I think that's really, you know, the first initial step of us preventing these.
Yeah, absolutely. And I think what we're doing here from the University of Montana, and I have some students working with me now, is really reviewing the antibiotics that are submitted. And I know many of you are submitting monthly to us, so that's fantastic. Thank you so much for doing that. What we do is we sit down and we look at those antibiotics that are prescribed. Some have indications attached, some don't have indications attached, but we look for anything in those antibiotic data sets that maybe looks a little bit off. So we'll look for things like carbapenem use. Are we seeing a lot of carbapenem use at an individual facility? We have one facility recently that we noticed is using IM ceftriaxone in, it's actually an outpatient facility, but they're using IM ceftriaxone preferentially over pretty much all of their antibiotics in their urgent care clinic. So it's something that we need to look into and maybe do some education on, because I'm reasonably certain that most of the patients that come through that clinic probably do not need IM ceftriaxone, and that there are probably some other alternatives that we can use instead. But that's what we're trying to do with the data that we get from you. And as we come up with these different trends, we'll provide some feedback to your hospital so that you'll have an understanding of what we're seeing from a stewardship perspective, and then be able to pass that information along to the providers. And I'm happy to answer any questions that you might have about that as well. We do have about 9 more minutes, I think, today. So happy to take questions not related to Amy's wonderful presentation. All right, well, in the absence of any questions, if those of you who are still on but have not chatted your information in, if you would please add into chat your name, your facility association, your title, and an email address, that would be fantastic. This way we can track and show the CDC that we do have people in attendance at these webinar series and that we should continue them.
And next month's webinar is canceled, so we will not be doing a webinar in July. However, in lieu of that, we are doing a survey. We'd love to hear your thoughts on the MASC webinar series, what your needs are, if this is meeting your needs, or if a different platform would work better for you guys. So please do fill out that survey. We are going to use the results from that survey to really help kind of further develop MASC and how we do these types of webinars. So please do that. It's due. I just kept the usual date of our webinar, so I just did July 6th. And no webinar next month. We'll start back up in August, and we'll kind of let you know the results of the survey at that time, and kind of if we're going to make any changes to this. So thanks, y'all.